Hello, I'm Dr Stuart.
And I'm Leah Tindale.
And this is our podcast called What's Up Doc, where we explore issues around health and in particular mental health. And this is a little bonus episode because this has been such a phenomenally successful series.
So popular. And we wanted to add in a little bonus about something that I think gets a little bit forgotten sometimes when we are talking about mental health conditions. And that is the carers who are and family members surrounding those suffering from mental health conditions. So I think to start, I really kind of wanted to talk about the cost and how much it does cost when you are, whether you're living with someone, whether you know of someone very close to you, and then how we can sort of, like the ways that it can cost.
It costs in every way imaginable, and I think this is quite a heavy subject, but I think it's important to cover as well, particularly in this context. And when I think about cost, I mostly don't think about financial cost, although clearly that is implicated.
Yes.
But for me, in these situations, when I'm visiting a patient or meeting with a patient who is suffering with mental health in particular, carer strain is what we term it, and it's just how much is this weight bearing on the other person in the relationship here, or the other people in this relationship here. Are they showing signs of burnout? Are they showing signs of relationship strain? Are they fighting with one another? Is there a bitterness developing? Are they becoming frustrated? Are they feeling guilty about the fact that they don't want to be a carer anymore? They didn't really sign up for that. We've all heard in sickness and in health, but actually when you're at the pointy end of that, it's a very different story. And especially when you're several years into that, it is a very, very difficult situation for a lot of people to find themselves in.
I think it's interesting as well, and very important to touch on, because often the carer will be very dismissive of their own weight, because they're seeing obviously their loved one suffering and they know how big it is. So they want to downplay, I'm fine, and all of that narrative. But when reality is you can't care for anybody if you don't have enough in the tank for yourself.
Absolutely, and that's exactly the line. That's exactly what I say to people is we need you to be firing on all cylinders so that we can do our best for them. And that's the challenge. And oftentimes the carer does not want the attention because they recognise that the other person has a more visible sickness and therefore that needs the attention, when in actual fact there are a lot of people sometimes in a treatment situation that we need to factor and consider in all of this.
Yeah, and I suppose the other thing as well, and I'm not sure if you've seen this in your practice much, but when then you downplay all of those things that are happening as the carer, then as a result, often you can be developing your own mental health conditions. I know a friend of mine who was the carer of her partner for a very, very long time, and started that relationship with just a little bit of anxiety, maybe a little bit of worry or whatever, but nothing that was needed to be medicated or anything. Ended 10 odd years later with panic attacks, anxiety disorder, a whole gamut of things, let alone health issues to do with the gut disorders, the whole thing because
absolutely.
She weren't addressing the weight. And I think that's so important that we give space to the carers as well, because
it's critical.
It's a huge weight to carry.
It massively is. And actually we need the carers to be in that role, because otherwise that person may not be fit to care for themselves. They may end up institutionalised or in a much worse situation, or they may become reliant on other family members who are in a worse position and less able to look after them. And you can see that interaction starting to seed resentment and anger and frustration. And you see the love necessarily fading from a situation, which is a tragedy. So there is a very complex relationship between a carer and a patient. And I think it's really important that we identify early where those strains exist. I always operate on the assumption there is going to be strain, regardless of where we are in that journey, because if it's gotten to the point where they're walking in to see me, there has been a journey up to that point, and there is definitely going to have been some form of strain. It may be very early days, but identifying it, watching for it, making sure that we catch it as early as we can and managing it appropriately is very important to me.
Absolutely. There's one big area of a carer's responsibility around mental health conditions that is a lot more heavy, but I think it's important that we touch on, and we should note this is trigger warning for anyone that may be familiar with or walk down the path of suicide and knows anyone in that space. But I think it's really important to touch on suicide, because sometimes, as well as a carer, you may not know when something is life or death, because everything feels life or death.
It does.
And you could also be not being manipulated, but being told things, and your perception is then different, and then the weight of that.
Yes.
So how do you even navigate that side of things, and what would sort of your advice in that space be, and
So
what to look out for?
What's important to me is to get across to the carer that they are not walking this journey alone. That there are people there, including myself, who are there supporting them. And they don't need to carry that burden on their own. They're not trained to carry that burden on their own. They are not expected to know. I have this conversation in the context of mums and young bubs. And a new mum often will be very nervous, and the bub will get a sneeze, and mum will come running in. She's very worried that I'm going to judge her for bringing a relatively well child. And I say, look, let's just check, make sure we examine the child. Very reassuring. I'd rather see them 100 times and reassure you than see them once and send them to hospital. But look, you get their whole life with them, and I get 10, 15 minutes with them. So if you're worried, I want to see them.
Yes, yeah.
I can then make the judgment. It's not on your shoulders. I can make the judgment based on years of experience, extensive training, and an understanding of the patient in context. So I absolutely hear what you're saying. And look, that's a nice way to put it, but in reality it might be a few days before the patient can get in to see one of us. If it's late on a Friday night that suddenly these symptoms develop, I might not be available to the Monday at the earliest, whatever. But there are other places. There's emergency departments, there's out-of-hours services, these kind of things. The point is, you're not walking this journey alone at any point. It might feel like there's just the two of you there, but in reality there's a whole team who is ready and standing by. It's just knowing where to turn to. But ultimately, I need to be the person making that judgment call. Do we need to be exceptionally concerned? I think any time people are talking about suicide, it's important to listen. For me as a medical professional. It's a word or a phrase that's used a lot. I tend to use it less. I tend to talk more about dark thoughts. I tend to talk more about hurting oneself or causing injury. But it's all around that specific area. And what I'm trying to identify is this just someone who just desperately needs the pain to stop? Or is this someone who wants to end their life? And that's an important and critical distinction for me. If someone is talking about not wanting to be here anymore, they are not really expressing a specific plan. They're just saying, I just don't want to wake up tomorrow morning. I haven't made any specific arrangements. They're talking to me about it. They've already spoken to their spouse about it. They're talking to anyone that will listen. That's lower on my concern than someone who has been brought into an emergency department, having been found, who has attempted to do something, who has tried to cover their tracks, who's maybe left a note, who has tried to do something that one could reasonably expect would have a fatal consequence. So some people will take a very small number of pills, and one would reasonably expect that that wouldn't have necessarily a fatal outcome. I mean, clearly any amount of an overdose can have a fatal outcome, but in reality oftentimes that's not the case. Whereas a more serious attempt would be something I would very much sit up and take notice about. So every single discussion around this absolutely should be taken seriously, and every doctor should take it seriously, and I expect would take it seriously. But we need to stratify the risk. I can't just send everyone to the emergency department or to a psychiatrist without stratifying that risk and identifying, is this something that we feel is critical? Is this somebody who needs emergency medical attention? Or is this just a cry for help because we have not got this right yet? And in those people, I need to instill some hope. As we talked about in the last podcast, there is hope. We just need to get this right. And it's telling me that I have not got it right yet. So let's make some changes. Yeah.
And so for the carer then, if they're coming in to see you, is it knowing those sort of levels of risk, and then knowing which ones, okay, well, when the person I'm caring for is at that level, that's when something that I should probably also maybe call or whatever, rather than everything feeling, because it can feel all huge,
Yeah.
you know?
And it is
And
huge.
it is.
Huge. It's scary for anyone.
And especially when you're living it in the day-to-day.
Even those of us who deal with mental health, including severe mental health on a daily basis, it's still scary when these situations happen. And it's very difficult. We rely on years of experience and training, and we do analyse a lot of the information we're getting and try and stratify that risk. But like I say, I would encourage a carer, if I was speaking to them, to not take on risk on their own. They don't need to, and that's not what's supposed to happen. If they're worried based on their experience with the patient and what they're hearing and seeing, I want to see them, or they should be in the emergency department. There are services who would be able to key in. It's important that if we are worried about that patient, we seek help.
Yeah, very, very true. I think the final sort of thing I just really want to hone in for anyone who's a carer is that you're definitely seen, that you're not a forgotten member of the family or whatever that dynamic is. And there is help available for you too.
There absolutely is. There's charities like Helping Minds. The Australian government runs a service called Carer Gateway. There's the Mental Health Carer Helpline. There's even Lifeline. There are lots of places people can turn to get support as a carer for someone with mental health. We can put links to that on the website. But ultimately, there is always support available, and the carer themselves will have to determine if they're really worried and they don't think this can wait till tomorrow morning. Likely, it's going to be the emergency department. But there will be support services in place, and it's just about having a recognition that something has changed, something is not right. Don't take a risk, leave it to the experts, go and seek some help.
Absolutely, and you're not alone, no matter
Absolutely not.
who you are, whether you're a carer, whether you're suffering, or whether you just want to be more compassionate and have more understanding for people in your life that you might know will be suffering. You're not alone, and we really hope that this bonus episode and all of our episodes have been beneficial. And thank you for sharing all your insights, Dr. Stuart. Always grateful.
For me too, always a pleasure.